good practices. So put your microphone on mute if you are not speaking. If you want to ask a question, raise your hand or write it into the chat. It will be easier. And I'm very, very pleased to, and the session, it will be recorded, so you can have an access for the member of SMA Europe, you can have an access after the session. I'm very pleased to introduce this talk. Nicole maybe will welcome you at the end or close the meeting. I will start, I think, with a project, how we have described this project. So the SMA Europe has this spin-off, I will say, with the SMA Newborn Screening Alliance. The objective of this Newborn Screening Alliance is to accelerate access to newborn screening. From now, we have between 35 to 40% of babies born in the EU screened, and less than 30% in all the Europe, if we consider all Europe in the large definition, geographical definition. And we continue, and we must accelerate this process, first to avoid major disability for SMA babies. So it's very, very important to accelerate the process. The SMA Newborn Screening Alliance has performed many actions to support national entities to apply for newborn screening in the different countries. We have the action plan, the white paper. Just notice that the white paper is now available in Spanish and in Portuguese, and in Romania, if you request it. It's very important for us to have these two new languages because we are in close relationship with ALAME in Latin America, and so they can use our white paper to apply for newborn screening in these places. We have also a very interesting webinar about technique for screening, and it's very important. And of course, the website of the Alliance will give you a complete overview about all the tools available and all the different papers, very important to apply for newborn screening. But what we are facing is that we have some bottleneck for screening. The first and the most important one, we have to go country by country to apply. We have no recommendation at the EU to support a new disease into the newborn screening panel. We have to duplicate the effort with different scope and important inequity from country to country. There is a very, very important question for me, this inequity from baby regarding the place they are born, regarding newborn screening. And if the rules and the question are more or less the same from one state to another one, but national authority not always read the data, the information we give the same way. So something who is approved in Germany will be considered as not efficient in another country. And it's very important for me to have this, to point this double level of lecture regarding the national authority. And in some countries, the way to apply, it's quite obvious. And it's very difficult to understand how we can ask for a new disease in some country. That's why we request, we work with CRA, and we have CRA, the company CRA, do a first report, very interesting, about the state of the art of newborn screening in Europe, not only for SMA, for all the disease. And it's very interesting to see that, of course, in Europe, newborn screening is state relevant in most of the country, but in some country it's also region relevant. For example, in Spain, you have to have newborn screening for each region, so that duplicate the effort. There are very important difference. There is a very important difference from one country to another one. If you look like to Italy, they are close to 50 disease screen. And if you look in Romania, there are only 2. In France, at this time, we had 7 disease only. So it's very big difference from one country to another one. And sometimes in the same country, you can have a baby screen for a disease in one region and 10 kilometers north, not screen. It was the case in Belgium with a pilot and an approval from the Wallonian part. And it takes months and months to be approved in the northern part, in the Flemish part of Belgium. So it's very interesting to have this. In the report, CRA identifies some key barriers, unclear process to apply for newborn screening, limited health infrastructure, time for implementation after approval, can be quite long, and a lack of funding. And they propose some very important for me key action that the process shall be transparent and well equipped to facilitate efficient and on-time evaluation of newborn screening expression proposal. The evaluation process of a disease inclusion shall be transparent. It's very important. And include external stakeholders like clinicians, of course, but also patient advocacy group, and have an appropriate funding. And that's one of the reasons why we decided, to about this non-institutional stakeholder. We have patient organization, a very important role to play. So in 2021, we launched a second survey led by CRA with the support of SMA Europe and the Newborn Screening Alliance and financed by Novartis Gene Therapy. This survey was to identify how patient organization can support newborn screening. The methodology was quite simple. Identify in each country what is the regulatory pathway for patient organization to apply or to support newborn screening. Is there a described way, or it's just informal discussion that patient organization can have? And we have launched a survey to identify the success story in the different patient organization, or also the difficulty they are facing. The result of all this work will be presented now by Christopher Jones from CRA. I let him the floor. We will have time for questions at the end of each chapter. So let Christopher present the slide, and then we have. If you have any question, you can raise your hand or put the question in the chat. So Christopher, is up to you now.
Great, thanks, Marie-Christine. And so I think just before we get started, so yeah, I think Marie-Christine's already given a very good introduction on all of this. And I think first just to say thank Marie-Christine and all of the other SMA Europe members who we've been working with over the last year, both on a regular basis and also everyone who has been completing the survey and who we spoke to in a series of interviews over the course of this year. Because ultimately all of this content we had in terms of the challenges that were encountered by patient groups across Europe and the best practices and the solutions that we're pulling out and recording in this toolkit is ultimately based on all of your experiences. So none of this really could have happened without any of you. And yeah, I'm very happy to see a few familiar faces from either our calls throughout the year or those who were in Barcelona the other week. So yeah, good to see many of you again and some new faces as well. Okay, so just to start with a general introduction. So I think just to say the slides we're going through today are basically the toolkit that will be shared later. So some of the slides are hidden just because we don't have time to go through everything in 45 minutes, and some are better to just read through than to present. But generally, we just want to provide an overview, a background, and also what the toolkit is, what the toolkit isn't, and to go through a few examples of some of these key challenge areas we've identified to show how this toolkit works and how we get to the potential solutions and strategies that can be used to address the challenges we've seen. So in terms of this toolkit, so this is more of a strategic document. So we're not like in some other materials which the Newborn Screenings Alliance has done or is working on. This is a strategic document. It's not providing an explicit template for how to write a letter or what to put in the letter. This is something to look at, as we said, based on the survey, what are the challenges that have been seen and how at a strategic level can we address these problems. And so one thing just to note is, so this is something that is focusing on SMA, but see, I think a lot of these challenges are things that are not necessarily SMA specific. And these are things which certain things people may have experienced and have overcome themselves. And also there may be other patient advocates who are just starting out. And so we're hoping by recording everyone's various experiences, this is something that can be useful to a lot of patient groups across Europe and maybe further afield as well. And so I think one of the things just to quickly say on the what this isn't, so none of this is mandatory. We are not telling you explicitly what to do. I think in some slides, which we'll get to later, we're explicitly saying there are multiple paths to go. Not everything works in every country. And there are obviously challenges that will be specific to your country, which we don't have in here. So just to be aware, we're not telling you what to do. These are just what we have seen from various groups across Europe. So it's just good to bear that in mind. Okay. So first, to start with the toolkit, we open with the survey and the responses we got. So for the actual survey itself, so this was the map of the respondents who we had, and one of the key questions we asked was in terms of, do you see patient groups as being formally involved in the expansion of newborn screening, or are you more informally involved through separate one-on-one meetings as opposed to being explicitly involved in a very well-defined process? And generally, most of the countries we spoke to didn't see any clear predefined role for patient groups in the process of newborn screening expansion, and very few countries do have this process available. However, I think it's quite promising that many of the patient groups who we did speak to said that even if there isn't a formal process, they do consider themselves involved either formally or informally, and have seen themselves as able to conduct activities to engage with and influence various stakeholders in their country. And then in terms of the key challenges, so we have the challenges a little bit more explicitly and broken down later on in the toolkit, and a lot of this was expanded on in individual interviews we did. But from the survey, essentially after grouping all of the various challenges we saw, there were a few key themes that came out, which we will see later on as well. So in a lot of cases, the pretty much all of the patient groups feel that the evidence to support newborn screening is there. However, the key issue is multiple factors, really. Getting the fact that in a lot of cases, the patient group might have some limited capabilities. There's not too many people. They're all volunteers. And then also noting that it can be difficult to provide this evidence to the correct stakeholders, and which links in quite nicely with the fact there isn't a clear process often. And also, even at the very basic level of having limited support from other stakeholders and actually getting your foot in the door, starting off engaging with these various stakeholders, whether it's the Ministry of Health or health insurance or other various parts of the healthcare system. And these are some of the various people who are identified. So just to note that the relative importance of these various stakeholders can vary by country, but this is sort of a summary of everything we've heard. And there's a lot of often interlocking stakeholders who are involved in the process of newborn screening expansion. So it can either be the Ministry of Health, who is often the person, well, the organisation which is ultimately making the decision, taking into account advice from multiple different sources. So these can be the payers, so this can be the national or the regional health insurance, who are ultimately the ones who are going to be finding the funding for newborn screening, any health technology assessment or HTA bodies. So these are organizations which are generally quite specialist and be involved in testing the clinical or economic viability of such a newborn screening program to determine if it is a good use of public resources. We can also have specialized screening committees themselves. So several countries do have an explicit screening committee available at all times, often part of the Ministry of Health. Then looking a little bit more broadly outside of those quite similar, often, as I said, they're often within the Ministry of Health themselves. You've got the politicians themselves who can add more pressure to the Ministry of Health and can continue to raise the issue, whether they are more local members of parliament or a national or even a European level. Then also there can be the ethical committees. So there are some concerns which some organisations may have with the ethics of newborn screening. So obviously there's people who need to be involved to make sure there's no problems there. And then obviously when we get to the physicians themselves and the patient groups, and often we found these two types of stakeholders are often intertwined and work together quite closely, as I'm sure many of you are aware. So basically the structure of the toolkit comes down ultimately to these 5 key challenge areas we've identified. So we'll go through a couple of these in more detail, but just to give a summary of them initially, and I'll add a little bit more information on some of the ones we're not going to go through the full slides on. But just the first one is, as I've said before, the lack of a process to actually include the patient voice in newborn screening. So we had that in the survey. There's either no process for newborn screening expansion, or if there is a process, it's not something where the patient group is explicitly involved in, with the patient groups often having to resort to informal measures to actually get their foot in the door and get involved in these procedures. And then the next one, which we touched on briefly, was the limited capacity. So as we said, many of you are parts of quite small organizations, largely volunteer driven. And there are examples where there may be some expertise in other parts, some of the technical aspects, for example, of newborn screening, which patient groups may not have. And these are some challenges we've seen quite often in terms of patient groups having activities they would like to do, but they require significant funding or maybe a lot of manpower, which they don't have time for. Or there may, as I said, there may be some technical aspects which they're not aware of. Then the third one, in terms of difficulty communicating arguments. So as I said, even if the evidence is available, the people who you are communicating these arguments to aren't necessarily always going to listen. And we did know that in a lot of cases, patient groups are having difficulties making their voices heard and making the case for newborn screening in an impactful way. Then getting into some more practical points. So even when newborn screening is approved, there can be issues in actually implementing the programs themselves, or in countries which have limited experience of genetic testing or of newborn screening as a whole. As Marie-Christine mentioned before, there's some countries which have a lot of different tests on their panel, some have very few or none. This can add a lot of significant barriers and costs associated, which healthcare authorities can be quite concerned about. And then finally, the legal and procedural delays and inefficiencies. So in some countries, there may be specific legal barriers that prevent genetic testing from being included in newborn screening panels. And see, if that is in place, that is quite a hard barrier to overcome before you even get to these next the steps we have above this. And then also there are these inherent inefficiencies and a lot of delays in the decision-making process. And I think after speaking to many of you, that we all know this is a very slow process. And whether it's a legal barrier or if it is just inertia within the government or the healthcare system itself. And then just a quick summary of the best practices. So I think something quite similar to this slide was shown at the SMA Congress, but this is something that's essentially just distilling down a lot of the guidance which we have throughout the toolkit into a few guiding principles and best practices. So noting that it's quite important to make sure that you are tailoring your arguments to the specific audience. So making sure you are aware of what the audience's situation is and what their goals and motivations are, and also what they can do and what they can't do, to make sure which arguments you have or which information appeals to them best. Then also similar point, but just making sure that you are considering any sort of local nuances. So for example, here how we have some countries have specific wording over heel prick tests or newborn screening, and just making sure you're using the right wording and not just necessarily taking what's something which has worked in other countries without considering your own local environment. And also that leading into the fact that in a lot of cases, we would prefer to use local examples and data to support your arguments where possible. And if not, using examples from countries which some have quite similar healthcare systems. Going into more of the communication and establishing relationships. So we found in a lot of cases that having long-standing and establishing these personal connections and finding a balance over, as you said, what can be quite a long time to make sure you are applying the necessary pressure, but also making sure you're maintaining the relationships with the people who are the key decision makers. And also making sure that you are continuing to collaborate with organizations which have similar goals. So we've seen a lot of examples working with other rare diseases organizations, quite a few examples of SMA newborn screening being included alongside SCID, for example. And then also making sure these can also be people like clinicians or scientists who are involved in the testing process as well. And finally, this point about encouraging holistic thinking. So something we've heard from quite a few patient groups is trying to get through the point to the Ministry of Health or various other organizations that newborn screening is not just one issue. There are a lot of other things that are involved here. And in a lot of cases, newborn screening is an issue across many rare diseases, and it is something that's going to become an even greater issue as more treatments become available. So, I mean, SMA has seen these problems now, but it is one of the first ones. And this is something that I think needs to be made to the government, that one, newborn screening, as we'll talk about towards the end with Rudolph, can help with cost savings itself, and also the fact that this needs to be seen as an investment in the infrastructure of, it's not just going to be SMA for newborn screening, there will be other tests coming down the line. So even if there are some costs associated to establish the necessary processes and infrastructure for newborn screening, specifically in SMA with the genetic component, this is something that will be used down the line as well. And although I think a lot of these arguments can be quite similar, in a lot of cases, there'll be the need for multiple different advocacy approaches across all of the different decision makers. And I think it's important to reflect on the arguments that are being used and how they've been received, just to make sure you are continuing to tailor and develop the appropriate and impactful arguments to make the case for newborn screening. So we have a couple of slides in the toolkit on supporting information. So, for example, we have a list here of different countries where we have some further information on who the key organizations are when it comes to approving and implementing newborn screening. So I think just to note, if your country is not listed, there are typically similar organizations in other countries, and this is something where we are potentially looking at updating this at a later time as well. So this is something that would be an obvious next step to update, but just something to note here. And then also we have another list of supporting materials. So as Mary Christine mentioned, there are a lot of things on the Newborn Screening Alliance and SMA Europe website, so that's obviously something that's very good to stay up to date. But this is just an example of other materials we had from either the Newborn Screening Alliance. We have something from the Portuguese patient organisations, also organisations like Screen for Rare and Screen for Care, which are doing separate work on helping with newborn screening. So it's just to bear in mind that there are other organisations and other pieces of information that are available if you're not aware of these already, which can help in the work you're doing. So I think before we go through the actual toolkit content itself, I just want to see if anyone has any specific questions or comments just before we start through that. Okay. And like I said before, I mean, if there's any other questions, we've got time at the end. And also if you want to put something in the chat, and that's something we can use at the end just to go through any questions. So just to talk about the structure of the toolkit. So we have the 5 key challenge themes, which we just went through on one of the earlier slides. And we're basically breaking down each of the challenges into a bit more detail. So going into what are the challenges that are within this overall theme, and then identifying a range of solutions that are provided, and then having specific information on how best to consider implementing a solution to a specific problem. And in each case, we have specific case studies from various countries, either from survey responses or from people who we spoke to in our calls, noting an example of this sort of challenge that we've seen, and also what the patient group has done to overcome it. So the first challenge theme that we had was this lack of process for the inclusion of the patient voice. So as we said before, this is something that is seen as a very common problem across Europe, either with there being the lack of a formal role for decision making, and in a lot of cases, the decision makers won't be actively seeking patient group input if there isn't a defined role for them. But this is something where it can provide an opportunity for the patient group to just create their own opportunities for influence, to get involved in the process, and really to make sure that the patient voice is heard. Then, so again, if there's no formal process, it can be challenging to actually identify both who they're meant to be engaging with and also who the key allies they can get, either in the clinical community or on the more political side, of who can actually influence decision-making process. And if there are these allies that are identified, these are people who can help support patients to amplify their impact on decision-making, either supporting them or in patient group advocacy efforts, or going separately and advocating themselves, or as a joint effort with the patient groups. And then also, with the lack of process, it can be difficult to establish and maintain contact with all of these people. And this is getting back to the point we had before about the need for establishing these more long-term relationships, which can help maintain the motivation to stay involved and to keep pushing at this issue to maintain newborn screening. And for each of these slides, so we're just going through it in a PowerPoint at the moment, but we do have these buttons throughout which are linked. So I should have gone through some of these ones on the earlier slide, but we do have a home button, we have left and right button to go through the slides, and then a button to go back to the previous slide you were on if you do click on a link. And then we have specific buttons for all the solutions and to go through all challenges, which is this slide we had here with all of the 5 challenge areas, and then additional buttons throughout on any supporting materials. So for example, the case studies themselves, or the additional resources we noted, or the key stakeholders. And then we can click that to just go back to the slide we were on before. So to break down the solutions a little bit more before we go into a specific one, a slide for each solution. So I think it's important to be strategic in the stakeholders that are targeted and to make sure to optimize how these groups are engaged or these individuals are engaged, and making sure to take into account you are aware of the capacity your organization has and to really identify what the key goals you have and why you're talking to these people. And to make sure the process for newborn screening is mapped out as early as possible to identify who the key people to engage with are and who to develop these long-term relationships with. So going into the 3 specific examples we have here, so just click on there. So the first one is to identify these key allies within specific organizations, so to make sure the targeted engagement efforts are appropriately made. So we've got a few ways here of how to think about this. So is it possible to identify someone, a specific individual who are likely to be engaged and supportive? So for example, if you can find a politician who has a relevant health background or an interest in healthcare policy, or even if they have any personal experience of rare diseases. If not, is it possible to identify a clinician as well, who has particular influence? They're an expert in this area. And also then, if you can't identify any of these people, is it possible to identify a wide range of people who can potentially be influential? And then to follow up with those who respond positively and to make sure to start targeting these stakeholders for engagement and to build those relationships. So from an individual level, for example, we had a point for Belgium. So as we said, where there are some formal regional processes in Belgium, but the role of the patient groups is often quite uncertain and there's no clear pathway. However, the SMA Belgium team, so they identified a member of parliament who had a medical and physiotherapy background with an interest in SMA and rare diseases. So this is someone who became quite a key ally to continuing to push the issue for the need for therapies, the need for diagnostics for SMA, and also the need to have this lifelong view of SMA management and therefore the value of having early diagnosis and early treatment. So it's just an example of an individual, of someone who can continue to push the issue and continue to support. And it's just one of the examples we have in the case studies. And then also from a clinical point of view, also we had an example from Poland where of identifying specific pediatricians or geneticists who have been involved in supporting both the advocacy and the implementation of newborn screening and have helped organize meetings with other stakeholders. So I think working with people from the testing side, in addition to just the clinical side, to make sure there is this platform that is available for clinicians and patient groups to engage with the key decision makers at the Ministry of Health. So to the next solution we have, so this is making sure to use, if there's any existing contacts and relationships, to generate leads and introductions. So see if there is an initial contact that is facilitated through an existing relationship, this is something where it's more likely to be accepted and more likely to lead to a longer standing partnership. So it is beneficial to maintain relationships with people who are likely to keep their jobs throughout periods of political change. So not just the MPs, but for example, civil servants or any key policy advisors, in addition to targeting the main decision makers themselves. And also getting in, it sort of ties into the point of, in a lot of cases with the patient groups not having too many people, there are other organizations with quite similar goals. So for example, any umbrella organizations within rare diseases, back to the point again with clinicians who can facilitate new introductions with the people involved in testing, and also maintaining these political contacts. So we had an example from Spain where the patient group there worked with the overall rare disease organization in Spain, who had a lot of relationships with the national politicians already, because essentially they were finding it quite difficult to work at a regional level because of Spain is a heavily regionalized country. So that provides a lot of difficulties there with having to engage with lots of different people. Whereas this rare disease organization within Spain did have a lot of the existing contacts with the national politicians. So these are people who could help facilitate meetings with key stakeholders to discuss newborn screening for SMA and to get this issue on the table. Then to the next one is to continue to develop these personal relationships. So it's making sure the identification of stakeholders and interacting with them to make sure they are the most appropriate for the challenge that you're trying to overcome. And it's really important to make sure that there's multiple different levels of how you can develop these relationships. So at a lower level, in terms of how much time and investment it requires, so there are the opportunities to pursue more informal calls and individual meetings with any allies or any decision makers, and then which requires a bit more effort going into attending relevant conferences and events to try and meet key stakeholders and start communicating some of the key arguments and to start linking different stakeholders together, as we made the point with clinical politicians and scientists and the patient groups. And then at a higher level, when it comes to actually organizing events yourselves, if possible, to establish this platform to make sure all the key stakeholders who are going to be involved in newborn screening ultimately are talking to each other early, making sure to get the key arguments across and to identify any other issues for newborn screening as early as possible. And then the second key theme that we're going to go through is on the difficulties in engaging and communicating on their arguments. So, like we said before, even if the data and the evidence is already available, it can be quite difficult to communicate these key arguments, and there may be some significant pushback against the arguments that are presented. So some of the sub-challenges we had for this was, for example, the patient groups might be a bit unclear on which arguments should be presented to which stakeholder or the level of emphasis on different arguments. So it's obviously quite important to make sure there are these targeted communications there. Then there might be some specific concerns that could be pushed back at the patient advocates. So the main ones we saw were economic, to some lesser extent clinical concerns, but then also implementation, which ties into economic quite a lot of the time. So there are responses that are needed to make sure these questions are addressed as quickly as possible to basically maintain momentum and to keep pushing for newborn screening without things getting bogged down. The final point on this, which we'll get into in more detail, was also on the relationship with the media. So this is a point we heard a little bit of mixed things on. So it's important to consider that this can be a powerful tool for advocacy, but also this is something that needs to be managed quite carefully to actually avoid any jeopardizing any relationships that there are with existing decision makers. So these sorts of these challenges are things that are quite common in cases where there are a lot of different stakeholders involved in newborn screening, as some of them can have quite specialized and quite different roles. And also in countries where there is quite a limited experience with newborn screening. So some of these people may need quite a lot more education than they could in other countries to get to grips with what exactly newborn screening is, what the implications for it are. And then also if there are any other issues with the government or the healthcare system, and getting back to the economic, I think particularly if they have issues with budget, which I'm sure most people will have heard from the healthcare systems, regardless of which country they're in, there always seems to be budget issues. And so going specifically into some of the solutions we have, so we can just go into the specific slide itself. So just to make sure that the arguments that are being used for newborn screening are things that are clearly linked to the goals and the situation of the audience you are communicating these for. So, for example, these are if the Ministry of Health is about to approve or has recently approved a new treatment. So obviously this can be linked quite closely to newborn screening. If there are treatments that are available earlier, there can be improved treatment outcomes, and also then there are even potentially cost savings as a result of that. Then if there's a new government or if there's an election, this is also something which can be involved in to make sure the public is more aware of it and can make it a bit more of an issue when it comes to any elections. Also, once the government has actually been elected, if you're in a situation where different parties are forming a government, then there is the opportunity there to try and get newborn screening involved in any sort of governmental agreement when forming a coalition. And then also, if the government has already demonstrated or has stated a dedication towards improving healthcare or access to healthcare, this is something that can be used to remind them of their previous commitments and to again bring back this key issue of newborn screening. So I think one of the examples we had here was with Romania. So I think Romania's very limited newborn screening, and there wasn't a clear process for patient groups to get involved. But I think one of the things that they noted was in a lot of cases of trying to speak the language of the Ministry of Health itself. So the Ministry of Health noted in a lot of cases around the right to health and healthcare in Romania. So that is something that kept getting used back with the Ministry of Health to sort of remind them of their obligations and to continue to push the issue of newborn screening. And then on the next one, so I think this, the arrows are a little bit complicated, but I think it's just highlighting the point again of making sure the information that is the most is communicated is the most important to them, but not necessarily ignoring other pieces of information, but it's just a case of prioritizing your time and also what they're most interested in or what their area of expertise is, and to provide the appropriate key supporting arguments. So we heard in a lot of cases that things like patient testimonies can be a lot more influential with politicians, members of parliament, and in the Ministry of Health, whereas when you're speaking more towards people in charge of hospitals or in charge of the health insurance or the health technology assessment, this is when the more targeted clinical data and any economic or cost effectiveness comes into play, because these are people who are much more technically orientated. And then on the more clinical side of things, looking more at any case studies in terms of best practices for newborn screening can be important for supporting implementation, and then also of the testing, but also implementation when it gets down to the clinical level itself of how the test is administered and how the results are reported to the patient's family. And I think a reminder again with the cost effectiveness, which is something we do have a few slides on, but we're just not going through it today because we do have Rudolph at the end to go through that. And then the next one we had in this is to prepare for the pushback. So as I said before, that it's quite important to anticipate and essentially come up with a list of what you think they're going to come back with to object to newborn screening, to prepare effective responses to these concerns. And some of these concerns can be quite similar. So I think the first one, we have the type of country, could be limited equipment or testing infrastructure, and they can say the equipment is too expensive. I mean, this is something that can be heard across many different countries as well, regardless of how developed their testing infrastructure is. But then there can be responses of really highlighting the potential for other tests that can be formed with the same equipment. So getting back to this point I said earlier, it's not just for newborn screening for SMA. This is something that can be an investment that can help numerous other diseases in future. So it's not just one fixed cost for one disease. This is something that can be used much more broadly. And then in addition to pushing this overall and lifelong thinking that the cost savings of having newborn screening can help support management and then offset any initial costs due to any reduced treatment costs over the lifetime of the patient, any reduction in any sort of social care costs, or parents or caregivers continuing to work. And there's many other things that can be considered in addition to just the cost of the equipment and the cost of the test. In terms of if there isn't any genetic testing or newborn screening in the country, regardless of if there's already a law in place against this or not, there are cases where people have said that genetic testing is unethical. I know Marie-Christine has had an example a few times of having to have some very interesting conversations with people in Parliament, of having to explain to them that newborn screening is post-birth. And there are people who don't seem to understand this. So in some cases, it is important to even just have a fundamental support a fundamental understanding of what newborn screening is, because sometimes you can be surprised how little some of these people who are supposed to be making decisions know. So it's just making sure of how people are aware of what newborn screening is and how this is different from prenatal screening, and ultimately what the results of these tests mean and how they are interpreted and what is done in practice once the test result is available. Then another thing we heard in quite a few countries is noting that if we diagnose more patients, we don't have many doctors to deal with it anyway, so we'll have more patients and we can't handle it. So it's even just an example there of noting that eventually these patients will be developing symptoms. It's not something that's not going to appear as a problem just because they're not diagnosed at birth. And bringing this back to the point again of that if there is screening, this can identify the patients earlier, it can support improved treatment outcomes and reduce the amount of care that's needed long term. So even if there aren't as many doctors, this is something where it can still be valuable because it can support better management over the course of the patient's life. And I think one of the examples we had here is, I think, with the, again, noting the fact of the cost effectiveness. So we have an example here for Romania, but I think, again, this is something we've seen in a lot of countries already, of really just highlighting the point that this is an investment in screening, and getting back to this point that it's not necessarily just about SMA, it's something that is important for many different patients, and it's not just a one-off cost for one disease. And then, so the last solution we have in this section is on engaging strategically with the media. So this is one of the points I was saying earlier about why we're not saying explicitly what to do, and why this is why you need to bear in mind your own local country specificities in the environment, whether it's in terms of the government or the government's relationship with the media, because we heard some quite different things. So the media can be a powerful tool to engage with for advocacy and can help raise a lot of public and political awareness for newborn screening. However, in some cases, we've heard this has been quite positive, and this has led to a lot of pressure on the government, which has helped. However, in other cases, this has led to a bit of backlash behind the scenes, where there's been a few people we've spoken to where they've said, after the media essentially made the government look bad, they found doors behind the scenes have started to close, and they found it a bit more difficult to talk to people within the Ministry of Health or politicians, because they just, well, they didn't appreciate the negative reception they got in the media. So it's just one of the things that is important to consider when deciding whether to engage with the media or not is, has there been any issues, and are you really struggling to get involved or get any responses from key decision makers? So is this the case where there is actually a real need to put pressure on decision makers through the public? Has there been any key examples already available. So there's been a few examples around Europe of specific children with SMA making it onto national or international news, and to build off the momentum that it has there. Also, if there is a need for fundraising and to increase public exposure and awareness there. So this is something where if you're already involved in discussions with decision makers and you feel that there is progress that's being made, it's something to consider that it might be better to focus on the direct communications and this targeted communications with key decision makers themselves, rather than getting the media involved because of the potential backlash I noted earlier. But if you are going to involve the media, just some of the things to consider is to potentially try and avoid some direct criticisms of any organizations who you might be trying to involve with in future, because these are people who you're ultimately going to have to be speaking to, and to maintain a positive relationship over what could be quite a long time. And as I said before, some of these criticism could damage your chances of engaging with these decision makers. In a lot of cases, when it comes to the media, I think we know, a lot of us will know quite well that when it comes to individual stories, these are things that tend to gain traction a lot more to appeal to the general public. And also to make sure that you have the capacity to maintain any momentum that comes as a result of these public campaigns. Because I think the example we had here from Belgium was noting that there was an example of a child which did make it into Belgian and also international news, for a child which was treated with Zolgensma, and they noted that initially it was very successful in raising awareness of SMA in Belgium and raising quite a bit of money, but I think, and also helping with newborn screening in Wallonia. But I think they did note that after a while it did sort of lose a bit of momentum, and then started getting bogged down in getting newborn screening approved in the other half of Belgium. And then I think the final point is just to make sure that, as I said on one of the previous slides, just to make sure that the information that's being relayed is as correct and accurate as possible. Just to make sure the journalists do have a very clear understanding of SMA and what's going on, just to make sure there isn't any reports in the media that are inaccurate, which could harm your case later on, and just to make sure that everything is presented as accurately as possible as it can be for any sort of public media campaign. And we just have a few minutes left on this section, but I think one of the things we have towards the front of the toolkit, but I've just put it in here for now because it fits quite nicely into this section, is we do have some specific messages for communicating newborn screening. So I think first of all, just providing an introduction of what newborn screening is and why it is needed. So we've got just a few brief examples for why it is ultimately becoming more and more urgent to have newborn screening as more and more treatments are becoming available, noting that there are examples of early diagnosis and early treatment are becoming increasingly effective in managing rare diseases, including SMA, and really just hammering home the fact that there is a need for newborn screening to make sure to improve patients' lives. And then the second one we have is, so just reminding the fact here that, so specifically looking more at SMA, but also a lot of these cases are very important for other rare diseases as well. But just noting that now we do have in SMA, now that newborn screening is available, noting that there are now clinical arguments and there are clear clinical guidelines across many countries that are now recommending treatment as early as possible, as there are treatments available, and also that there now is increasingly strong evidence noting that there is the potential to improve outcomes by treating as early as possible compared to waiting until later. And also just noting just how much newborn screening has changed the prognosis of diseases such as SMA by providing this early treatment, and noting that if there isn't newborn screening, rare diseases like SMA can typically be diagnosed by the clinical presentations and symptoms, and then leading to subsequent testing after that. But as we know, throughout rare diseases, including SMA, there is generally a lack of awareness of a lot of these symptoms, and there's a lot of inequalities in various healthcare systems. So there are a lot of delays in diagnosis, and there is a lot of monitoring that's required to detect diseases early, compared to if newborn screening is available. And so I think before I hand over to Rudolf, I think this was just a section I had if I got through things more quickly than expected. So in the back end of the toolkit, we do have the supporting case studies and also the examples of the countries, which I said before.
Question.
Oh, yeah, sorry.
I think we just had a couple of questions there before we move on.
Oh, sorry. I didn't see the hands up. Okay. Yeah, so yeah, I can see Mary-Christine and Jonathan.
Go ahead.
You'd like me to go first? Chris, thank you for a really excellent presentation. I think as SMA Ireland right now is in the middle of, we're at the tip of the spear really of a big campaign. And I mean, it's basically that presentation is like you're living inside my head. So, you know, it was very encouraging to anyone who is about to embark on this. Everything in those slides is real. So addressing the ethical concern, it will be different in other languages, but in Ireland, we also encountered this mental block that people have about when you say newborn screening. They do think about amniocentesis. They do think about in utero testing. And so we are very careful to always address it in kind of layman's terms, the heel prick test, which works well in English. It's what housewives would know it as. So my one tip would be, if such a colloquial language exists in your country, I would be strongly recommending that. We'll hear later in the presentations, the economic arguments don't stack up, especially when it comes to SMA. They have been rebuffed. We all know that it's actually cost positive, or whatever the right way of phrasing that is. The one problem that we've encountered, and it's something that I just wanted to share, it's really just inertia. There is a one-size-fits-all approach, whether you're talking about screening for cancer. So the BRCA gene, for example, which does raise ethical considerations. When do you tell the person? Should you tell the person? What are the implications for their health insurance, etc., etc., etc. With SMA, this is irrelevant. It's especially irrelevant in Ireland because Zolgensma's been approved. So you've got this ludicrous situation where children will get the drug once they present, provided that, you know, they come up symptomatic, say at 12 months. But they could have been caught at a month or even earlier. So the inertia, what the argument that we're trying to push forward is the which it wasn't referred to here, is to trying to get a trial, a pilot study, and to use that as a back door, because the whole process is taking far too long. And a really important final point is the European comparison is also really, really valuable. So right now, for example, in Ireland, we test for 9 diseases. The European average is, I think, 16. So, you know, we can kind of tap on the politician's shoulder and say, you know, listen, you're falling behind here. Everyone else is doing this. It's just a question of when, so get on with it. Anyway, I'd stop there. I could go on forever.
Yeah, no, I think it's good to hear it's matching up with your saying, well, what you're expecting. Well, I mean, it's not good because we'd rather everything went nicely, but it's good to know we're catching the right challenges and just making sure people are aware that these things are going to be coming up. So Mary-Christine, I think you had your hand up as well.
No, I just want to point that you show some very interesting point in your study, but there are also very important point in other chapter of this study. Just to be clear, when will this be available on your website? And I think we will put a link on the SMA Newborn Screening Alliance and also on SMA Europe or this SMA website. So just to be clear for everybody, but they will be very soon available on for everybody to have a read on it.
Yeah, like I think everything's been reviewed. I think it'll just be a case of we'll have a final look through. I mean, make sure all those buttons and links I was pressing work, because they did in this presentation and hopefully they all work. But we just want to make sure, and then, yeah.
But if any country, I think about Romania or maybe Ireland, need to have an early access, please come to me and we will give you an early access to this document. It will take a few, I don't know, days or week to be publicly available. But if you need to have an early access, do not hesitate, because there are also very, very important things in all the chapter of this document. And thanks to Christopher, they performed to have a very nice summary about a lot of information, and it's very important for all of us. Maybe now I give the floor to Rudolf regarding cost efficiency.
I think you see my screen now.
Yes.
Yeah, super. A couple of words about newborn screening in SMA by the heel prick, as Jonathan mentioned, and then focus on cost effectiveness. But first, I need to use this one. First, a couple of words about the screening technique. The whole screening by the heel prick is focused on the homozygous deletion of the SMN1 gene. We all know that. And given that humans have a backup gene of SMN1, the SMN2 gene, screening tests available are sensitive to detect the differences on some nucleotides, especially difference in exon 7 and 8. And up to now, it's standard practice to use a two-tier diagnostic procedure. We all know that, hey, first screening in newborns, focus on the homozygous deletion of the SMN1 gene, and afterwards the second test to validate the SMN1 deletion, as well as to detect the SMN2 copy number, important to take decisions related to the difference in labels and reimbursement criteria in the different countries around Europe. Important to realize that all the screening methods, there is always a very small risk of false negatives due to the point mutations of the SMN1 gene, which lead to a non-functional SMN1 gene. The cost per screening test, we all know it's less than €5 per newborn screened. And when the volume is going up, the price is going down. That's the normal economic laws. What about cost effectiveness? One of the important questions we had in 2019 is newborn screening in SMA cost effective? And given the treatments available and the possibility to screen effectively in the first week of life, we asked the University of Groningen in the Netherlands to help us with the comparison with the situation with or without screening and the impact on incremental healthcare costs versus the incremental healthcare benefits. Now, although this is a simple question, to get the data right in a model is not that simple. And together with our global health econ group, especially Matthias Bishop, we worked with the University of Groningen to develop a working model to screen or not to screen from a health economic perspective. Key question is newborn screening cost effective? And to answer this question, we need to look at the impact of screening on the incremental costs, the y-axis, versus the incremental effects on health outcome, the x-axis. And when you are in the right upper quadrant, you will see a result with a higher incremental costs and higher incremental effects in health outcome. But in the right lower quadrant, you see higher effects, incremental effects on health outcome, but with lower costs. The impact of the results in the upper right quadrant are related to judgment and evaluation of the willingness to pay threshold, and that could differ per country or per region in the world. The impact of results in the lower right quadrant are dominant cost effective. Recently, in Australia, investigators have published the results of at the left upper part, the cost effectiveness of newborn screening in SMA, and then the middle part, the newborn screening in SCID, an immunodeficiency disease, as well as lower part, the newborn screening with SMA combined with SCID. And we know the screening test of SMA could be easily combined with SCID, and some companies are offering these tests even in one test kit, like PerkinElmer, as well as ImmunoIVD, the Swedish company. And the results of this research portfolio from Australia is positive in all cases, means value for money. And just to focus on the right upper part, newborn screening on the SMA, the investigators here compared the implementation of newborn screening combined with gene therapy versus newborn screening with nusinersen treatment or with no newborn screening with nusinersen. The analysis is different from the work we have done, which will be I will discuss in the next slides. However, and we need to focus on the first to the Australian work. A positive editorial was written in the same journal with the interesting title "Maximizing Returns," with the focus on immediate treatment of the SMA babies detected with newborn screening, in this case by gene therapy. But we also know on the right part, also in Belgium, they have published a financial analysis with a reduction of societal costs as a result of the implementation of SMA in the newborn screening panel, at least in the southern part of Belgium. And our work at the bottom of the slide is published now in Value and Health last month in October, a cost effectiveness analysis of newborn screening in SMA in the Netherlands. And important to mention is that this is an impressive work for the last 2 years, together with many stakeholders to get the model fueled with all the data needed. And just a couple of technical slides, but the basis of the paper is to combine two submodels. The left part, you see the decision tree, and you need to combine that with the right part, a Markov model, the most common type of model used in health economic analysis, with a follow-up of patients over time. And the model needs to be fueled with screening parameters, epidemiology data, clinical aspect, costs, utilities, and so on. And we don't go to all these details, but it's just to be aware. In this slide, you see the decision tree with different steps, screening versus no screening, and the implementation of false negatives, limited amount, as well as a diagnosis of symptomatic patients over time related to the different copy numbers of their SMA2 genes. But the point, of course, is what are the results? And the results for the Netherlands, a country with about 170,000 newborns each year and an incidence of SMA of 1 in 10,000. And the most important results you see in the red boxes. With screening, an increase in life years, as a medic immediately I'm impressed, is gained 283 life years in this model. Unbelievable. And in addition, the incremental costs are negative, 12 million euros negative over the lifetime of patient diagnosed per year. And there is a massive gain in quality adjusted light years, 320 QALYs. Behind the model, we have a discount ratio of 4%. It's a lifetime follow-up and a payer perspective, but that's technical. But the key message is, hey, screening is and cost-effective and cost-saving methodology, which will create a lot of benefit. And we all know that also from a clinical perspective. This model was also the basis to review Ireland, Portugal. These were two posters recently presented in the SMA Europe conference in Barcelona with the same outcome. Increase healthcare benefits, decrease costs on a dominant way. And I think you have seen these posters, or at least they are still available from a digital perspective. Now, and to summary, hey, the question is newborn screening for SMA cost effective? And yeah, the answer is yes, because besides our model, we have seen that in the model of Ireland and Portugal, as well as in all the Australian papers, as well as in the Belgium message. And related to the Belgium message, we all know that Laurence could, in a fantastic YouTube summary, give the story, and I don't share the link is here, but hey, he is mentioning that in a couple of minutes that no screening on SMA is costing the society €4 per second in a Western country. And I'm happy to take any questions.
Thank you. Any question? Just to tell you that I have a different paper available on, but not on such a simple way, but the full paper available on our website, SMA Europe website. Casper?
Well, I would say it was amazing presentation. Actually, I liked it very, very much. Very concise and really to the point. That's something, a kind of a message we should be conveying at every meeting, each meeting with the authorities in different countries. So Rudolf, I mean, it's great. This is really, you've done it very well.
Thank you.
And inspiring for me, because I'll be presenting in Romania in 2 days from now on a Friday. Yeah. So that's something that I'll keep in mind and perhaps borrow some ideas from your presentation about cost effectiveness. I wonder, we saw the post from Ireland, from Portugal, from the UK. I'm sorry, I might have missed some of the posts. Do you have other countries at hand? And if so?
No, the UK was not there yet. So there were Ireland, Portugal, and Japan was presented in Barcelona.
Ah, all right. Okay. Okay. Yeah. So sorry, UK wasn't presented. Yes. Okay. Right.
But that will follow later. But because they are busy with an analysis. That's sure. Yeah.
Mm-hmm. If you have any further countries that would follow, I'll be interested to know.
Yeah.
There will be Greece, I think, Rudolf, coming soon. Greece is coming soon, isn't it?
Yeah, it's also in process, but soon is always.
It's in process.
But I'm feeling the push.
Right. Do you have a list of countries that are forthcoming?
No, that's not public. I think. Yeah.
All right. Okay.
But we can confirm that there are some countries that are on the radar, and some countries are already working locally on the cost effectiveness model in their countries.
Mm-hmm, mm-hmm. All right. All right. So I'll liaise separately, not publicly then.
But important to realize that I forgot that to mention. When you look back to the development of the newborn screening panels in the world, and the decision of health authorities to add a disease, often cost effectiveness was not taken into account, because it's the medical agenda what was the most important point. Like, for many diseases in the Western European countries, but also Eastern European countries, cost effective was not part of it. It was, have you the possibility to pay the screening test? That needs to be cheap, as well as it's a limited amount of the there's always rare diseases, and when you are, for me as a medic, all the health econ work was just a validation of what we know from a clinical perspective. When you reduce the morbidity, you are reducing costs over lifetime. So that we need to convince the health authorities, because in the end of the day, it's a simple message. So I tried with the slides with the x-axis to make it understandable for people who, and it's not, there's no need to when you look at the talks at ISPOR, that's about a lot of data and variabilities, and that's, in this case, value for money.
Yeah, exactly. Well, many countries do not have a process of legislative process of doing HTA to a preventive program, to a public health program.
Yeah.
There are HTA for drugs, for pharmaceutical products to be reimbursed. That's how it's limited. So frequently, even if, for example, in Poland, even if the ministry would like to have an HTA done on newborn screening, the current law legislation says no, HTA is for drug reimbursement and not for preventive programs, right? So I mean, it doesn't include preventive programs as like something that can be commissioned to the HTA agency. So you're absolutely right in that. So we need to generally convince payers that there's something that has to be done as a preventive, as a prevention. And it's not because it is cost effective, it's just because one of plethora of public health measures that have to be taken by the authorities. All right.
Thanks.
Thank you.
Yeah, I think it just gets back to that. I'm sorry. No, I was just going to say, I think it just gets back to one of the points we had earlier about just it's trying to have arguments and evidence to like swat away any objections you get. Because as you said, like the cost is maybe a little bit further down the line when you can say there's a clinical reason, there's all these other reasons, and then it's just one of the few arguments they've got left, I think, when they can say, oh, we can't afford it, and then you can say, well, actually we can, and here's why. It actually saves you money. It's just
and here you are saving money. That's the key message, because that's what we have never seen, or not that often. When you add a contribution to healthcare, people are thinking, hey, cost money, but now, hey, it's in the right lower quadrant, means cost saving and increasing healthcare benefits. Yeah, that's the key message.
I fully agree with Christopher. When you have put in front all the medical and the benefit for the family and so on, you always have a question about cost. The cost of screening is very important, and the cost effectiveness. And at the end, you have this question. Once you have this question, so if you go to your health authority, you need to prepare the answer. But it's not the most, the first one, but it comes anytime it comes. And it's very important to be able to show that it's cost effective and the cost is not so high than that the health economy, the health authority imagine, because the cost of screening is not so high, especially if you have already a screening on SCID or something like that.
Yeah, I think one thing, Rudolf, as well, which I was just thinking, so I know we've had this point before about needing to consider all the various factors and benefits and costs that go into SMA. So I think the model was incorporating not just like healthcare costs, but I think it was looking a bit broader than that. Like, I don't know if there's any way, is there like different versions of the model where you look at overall costs like health and social and then just health? Because I know some countries, they are very focused just on like healthcare costs, and they, despite the fact it's all public money, they don't necessarily care about social costs, even though it's all tax money.
Yeah,
all going.
That's a good question, Christoph. But here you see from a payer perspective, because that was the way. And of course, we focused on healthcare costs, but then you are already dominant.
Yeah. Okay. Yeah.
So then you are already dominant. So that's you are immediately. It's the best for society.
Okay.
So I clearly encourage all of you to go through, of course, this document and this webinar when you are applying for newborn screening, and also to see the full publication. It will be very, very important to have this full publication. It's very, very interesting before addressing. I have in mind 2 countries, especially it's Romania and Ireland, where I think we will send a first slide without being public, because it's important to have this at this time. Thanks very much to all of you, especially to Christopher and Rodolphe, to finalize and to present it. It was a very interesting thing, I think. It's a seeing panel. And you will receive, all the members will receive a message as soon as the publication will be, the document will be publicly available, so you can have a look by yourself inside. Thanks to all of you. Have a good evening.
Thank you very much indeed.
Thank you.
Thank you. Bye-bye. Bye.
Bye.
Thanks.
Thank you. Bye-bye.
Thank you, everyone. Bye.
Bye.
Thank you. Bye-bye.